Cummings, Otology, Section 2, Diagnostic Assessment, Chapter 134, Diagnostic, Audiology, and Electrophysiological Assessment of Hearing. Objective tests for differential diagnostic applications. Autoacoustic emissions. Quite until quite recently, the term objective test, when referring to auditory system, denoted exclusively the measurement of neuroelectric events associated with auditory stimulation, beginning with Paulin Davis's discovery of cortical auditory evoked potential in 1939. The discovery of the ABR by Jewett and Williston marked the beginning of a veritable revolution in the clinical application of auditory electrodiagnostic tests. Indeed, the ABR changed the way hearing was tested in newborns and infants, and it also provides physicians and audiologists with a reliable and informative neurodiagnostic tool and a reliable technique to monitor auditory function during surgery. With the discovery of the evoked autoacoustic emission OAEs, it became possible to analyze and investigate auditory function from hair cells to the auditory cortex. However, OAEs are not electric events, rather, they are audio frequency signals that can be recorded with a sensitive microphone placed in the external ear canal by use of sophisticated signal processing, and they are thought to reflect the motility of the cochlear's outer hair cells. It is thought that the active motility of outer hair cells serve as an amplifier of the displacement of the cochlear partition, which results in various forms of OAEs as byproducts detectable at low intensities. These acoustic byproducts of outer hair cell motility are often referred to as cochlear echoes. Acoustic emissions may be divided into spontaneous emissions, which occur without acoustic stimulation of the ear, and evoked autoacoustic emissions, which represent a response to an acoustic stimulus delivered to the ear. The evoked OAEs may be further subdivided into transient evoked autoacoustic emissions TEOAEs elicited by a transient brief stimulus such as a click or a brief tone burst. Stimulus frequency or acoustic emissions elicited by a pure tone and distortion product acoustic emissions DPOAEs generated by pure tone separated by specific frequency difference. With some exceptions, evoked OAEs may be obtained from essentially all ears with normal hearing and may be reduced or absent in ears with hearing loss beyond 35 to 40 decibel. Compared with evoked potential measurements, one of the advantages of evoked OAE measurements is the simple and brief patient preparation and examination. The test requires a probe that contains both a miniature loudspeaker and a microphone to be sealed into the ear canal. The stimulus that elicits the evoked OAE is delivered by the loudspeaker, and microphone samples the output or the emission for approximately 20 milliseconds after stimulation. The outer output from the microphone is filtered, amplified, and averaged to enhance the signal noise ratio. TEOAEs consist of a delayed echo of the stimulus and a span of frequency range between zero point 0.4 and 6 kilohertz. The latency is typically 5 to 20 millisecond in humans, and the amplitude tends to decrease as frequency increases. DPOAEs are elicited by two stimulus tones delivered at a 55 to 85 decibel sound pressure level SPL separated in frequency. The most prominent DPOAE occurs at a cubic difference frequency described by the expression 2F1 F2 in which F1 represents the lower frequency stimulus and F2 represents the higher frequency primary tone. The resultant emission typically has an amplitude 60 decibel lower than the level of primary tones. It is advantageous for the two primary tones to be 10 to 15 decibel apart. It has been shown that little intra-subject variability is apparent in OAE measurements and that such measurements are stable over several years for any 1 year. In addition, OAEs provide functional information about well defined frequency specific regions of the cochlea, thereby facilitating the tracking of change in inner ear pathology characterized by outer hair cell dysfunction such as noise induced hearing loss or ototoxicity. Illustrates TEOAEs and DPOAEs obtained from the same normal hearing individual. OAEs may be useful as differential diagnostic tools for acoustic neuroma and also for treatment planning. The presence of robust OAEs indicate good cochlear outer hair cell integrity, and this may serve as supplemental information to support a planned hearing preservation surgical approach. In addition, as described later in this chapter, OAEs represent an integral diagnostic measure for the diagnosis of auditory neuropathy or dyssynchrony. The following case illustrates the differential diagnosis of use of TEOAEs and ABRs. A 53-year-old patient in good health noticed high pitched tinnitus in his left ear. Pure tone audiometry revealed normal hearing bilaterally through 2000 Hz with bilateral notches at 4000 Hz at 20 decibel in the right ear and 25 decibel in the left ear. Speech recognition scores were excellent, 100% for right ear and 92% for left ear. Because of the presence of unilateral tinnitus, however, ABR testing was carried out as illustrated in figure 134.7. All of the component peaks of the ABR were present with both left and right ear simulation. However, although the 1 to 3 interpeak latency was 2.28 millisecond for the right ear within normal limits, it was outside the normal limits in the left ear 2.58 millisecond. Magnetic resonance imaging MRI identified a 7 millimeter enhancing mass in the porous Equisticus region of the left internal auditory canal. OAE testing was also carried out to determine whether any significant cochlear involvement was evident. This consisted of reproducible emissions at 1000 and 2000 Hz, 72% and 92% reproducibility, respectively, with no discernible emissions at the higher frequencies. Despite the minimal high frequency hearing loss, their result indicated some early subclinical cochlear involvement. Although this is still somewhat speculative, our observation is that impaired OAEs in patients diagnosed with an acoustic neuroma indicate a poor prognosis for postoperative hearing preservation. Thank you.